Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Understanding Fentanyl with James Kowalsky. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. A recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digitalized journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note the evaluation will close at midnight on Monday, September 6, 2021. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certification of attendance if you are not attended the entire webinar, and we are not permitted to provide partial CE credit. James Kowalsky is a public health program specialist with the Illinois Department of Public Health. He manages HIV prevention grant that funds HIV and STI testing, behavioral interventions, linkage to care, and harm reduction services across Illinois. Since 2013, James has been providing training and technical assistance to organizations adapting their practices to incorporate harm reduction, housing first, motivational interviewing, and trauma-informed care. James and his wife, Susie, provide training and consultation through their company, Practice for Progress. James is a member of the Motivational Interviewing Network of Trainers. He's received a master's in social work from the School of Social Service Administration at the University of Chicago. James is committed to promoting a shift in public policy and service deliverables that is characterized by acceptance and respect for people who use drugs, have substance use disorders, or are in recovery. And now I'd like to welcome our presenter, James Kowalsky. I will turn the presentation over to you.
Thanks, Becca. I appreciate that very nice intro. And I assume everyone can hear me okay. If there are any sound problems, please let us know in the chat. Oh, Rebecca, can you get us switched over to the other slide deck?
Can you see your slides now, James?
Not yet, no.
Please bear with us just a moment.
There we go. Great, thanks so much for taking care of that. So we're here today for the topic of understanding fentanyl. And I just want to first off start off by thanking FATA and for bringing this topic to you all, for bringing me here to talk to you all about it. And also a special thank you to Eric and Becca for doing all the technical stuff today and leading up to the event so that we could have this webinar today. And then thank you to all of you for attending, for making time to be part of this webinar, for giving your attention to this. I'm sure, like many people working in the field of substance use treatment, that you all are being pulled in many different directions. There's treatment plans and progress notes that need to be done and meetings that need to be had, and there's probably someone knocking on your door or calling you right now. So thank you for taking the time out, because I do think this is a really important topic, and I'm glad that we're here to talk about it. So my name is James. Becca gave me a really good intro and talked a little bit about my background, so I won't get into too much of that. I will say, you know, my wife and I both, Susie and I, we both do training for Practice for Progress, so you may have seen her do some training on trauma or harm reduction as well. And what I will just say is I am deeply passionate about the people that you all serve in your programs, about people who use drugs and people with substance use disorders. And I think that there's so much that we can do to help them. And so this topic in particular, I hope that there's information here today that you can bring back and make use of in your programs. And what I'll also acknowledge here is you all do have a lot of experience with the topic of fentanyl, certainly more than the average person. And so, you know, as things occur to you throughout the training, feel free to use the chat to communicate with each other and with us about some of your experiences of working with people who have used fentanyl or been exposed to fentanyl, you know, in their drug using. And then also feel free to ask questions throughout the presentation this morning. There will be a brief break at the halfway point. You don't need to hold questions until the midway point or until the end. We'll check for questions at that time, but as I see questions come up, I will try to answer them when appropriate. Here's our objectives. These are very long objectives. What I will tell you is sort of the more general outline for today is we're going to talk a little bit about kind of understanding the role that fentanyl plays in the ongoing overdose crisis. We're going to talk a little bit about kind of some details related to fentanyl, understanding some of the myths about casual exposure to fentanyl. We're going to spend some time talking about, you know, what are the potential solutions for trying to pull us out of this overdose crisis and the role that fentanyl plays in it. So hopefully we get kind of a nice overview of fentanyl, but also coming out feeling like we have some strategies and solutions to take back to our work with us. So where I'd like to start today is by acknowledging that today is August 31st. And for those of you who don't know, August 31st is International Overdose Awareness Day. International Overdose Awareness Day is a time to remember people who have died from drug overdose death. So where I'd like to start is just by taking a moment of silence to honor those people who we know in our lives who have, whether personally or professionally, people we know in our lives who have died from an overdose death, but also to hold some space in our hearts and in our thoughts for the thousands of people who have died from drug overdose death who we will never know. Thank you. What I want to say is that too often, when it comes to a substance-related death, the grief that people feel when they experience someone who they know or who they love dying from an overdose, that grief is really stifled by the stigma against people who use drugs. And people, you know, who die from an overdose death are sometimes blamed for their overdose or for their death, as though they wanted that to happen or intended it to happen. And we know so often that essentially what's happening is accidental, that people don't want to die when they're using drugs, that very often they're seeking some sort of relief from pain or suffering that they might be experiencing, or just trying to seek to alter their state of mind, whatever reason people have to use drugs. But we know that people who use drugs are so much more than just the drugs that they use. You know, they're brothers and sisters and parents and grandchildren. They have whole lives and whole personalities. They're funny and sweet or caring, outspoken, humble. There's so many things, you know? And when people die from an overdose, it creates a ripple effect. It causes pain that just resonates for years and for generations to come. And so, you know, Overdose Awareness Day is a time to both make space for those people who have been lost, but also to try to raise awareness to prevent any future suffering caused by drug overdoses. So, really significant that we're here today to talk about this issue. I think many of you know this already, but the trend in overdose deaths is that they have been on the rise. They continue to rise. And so this graph just shows you total overdose deaths, total drug overdose deaths in the state of Florida over the past 5 years or so. And you can see there was a slight dip, and this actually followed national trends around kind of from 2017 to 2018, 2019, depending on what part of the country you're in, but that those, you know, number of overdose deaths have actually rebounded and surpassed where they were before. This graph right here shows a more detailed breakdown. This is based on national data. And what this shows you is the overdose deaths in the USA by drug type. So the black line that you see at the very top are all opioids. So opioids are the most commonly used drug that is involved in overdose death. And when we say involved, the significance of saying the word involved is that very often drug overdose deaths involve multiple substances. So for instance, if you added up all of the numbers here, you would have a number that's greater than the total number of overdose deaths in the country, because very often people are using multiple substances when they experience an overdose death. But just underneath that black line, which is all opioids, is the brown line. And that brown line represents synthetic opioids, or most commonly things like fentanyl. And synthetic opioids are the most prevalent of any particular type of drug and the most prevalent opioids. And you can see that's been the case for about 5 years now, where synthetic opioids surpassed heroin as the most commonly, as the opioid most commonly involved in overdose death. Now, a couple other trends that are worth noting here are where you look down the graph a little bit and you see both the gray and the pink line. So the gray line represents psychostimulants, so that's things like meth, and the pink line represents things like cocaine. And you can see both of those are trending upwards, whereas things like heroin and natural or semi-synthetic drugs, which are usually prescription opioids, those have sort of remained flat or have actually started to come down a little bit in recent years. So significant increase in fentanyl overdoses, and starting to see increases as well, concerning increases in both cocaine and methamphetamine involved overdoses. And this trend really mirrors pretty closely what's happening in Florida. The only difference that I've seen in the data that I've seen about Florida is that cocaine tends to be a little bit more common than methamphetamine in Florida when compared to national statistics. One more graph I'll show you here, and this just sort of illustrates what often is talked about as the 3 waves of the rise in opioid overdose deaths. So what you see is the rise in opioid-involved overdose deaths. You can see that top black line, which shows all opioids, and that has sort of just been steadily increasing since the 90s. And where it first started to increase, it matched very closely with a rise in prescription opioid overdose deaths. So that's considered the first wave of the opioid overdose crisis. The next wave happened as crackdown started to come on prescription opioids. We saw a shift to people moving into illicit opioids, most commonly heroin at the time. And so then you see, as the prescription opioids sort of tail off, heroin starts to rise up. And then very similarly, as heroin starts to tail off or plateau, synthetic opioids rise up to take their place. And so that's the third wave, is the synthetic opioid overdose deaths, most commonly attributed to fentanyl or fentanyl analogs. So we'll jump in here now. So what is fentanyl? Fentanyl is an opioid. It is related to other opioids, things like morphine and codeine and heroin, but it's synthetic. So natural opioids are derived from the poppy plant. Semi-synthetic take elements of the poppy plant and then combine them with other chemicals. But synthetic opioids are created completely absent the use of natural elements, like using the actual poppy plant. Some of the other synthetic opioids that you may be familiar with. Obviously, we know about methadone as a common treatment for opioid use disorder, but also there's more powerful synthetic opioids that are very closely related to fentanyl, and the chemical U47700 is an example of that. Fentanyl falls into what are considered novel psychoactive substances, NPS, sometimes called new psychoactive substances. So it fits into this category of NPS, and NPS kind of have had different names over the years, but NPS have been around in some form for over 30 years at this point, and they're also at times referred to as designer drugs. Typically, NPS are things that are trying to replicate or mimic the effects of other drugs. So other common NPS include things like synthetic cannabinoids, like K2 and spice, or synthetic cathinones, like bath salts or flocka. So we've heard stories about flocka, obviously, in Florida, and so that's relevant there. And then I just sort of put down here as sort of a comparison point. So where cannabis or marijuana has an NPS equivalent of K2, the NPS for heroin is fentanyl. Right? These are drugs that are manufactured using legal ingredients that might not be regulated themselves, and are created in a laboratory setting usually. I will also say there are some things sometimes they're referred to as legal highs, because there are some places where before the NPS becomes outlawed, it is available legally. So that's part of where NPS come from is, because certain substances are illegal, NPS are designed to kind of go around the law, provide a way for people to get the same effects without actually having to be exposed to the potential legal risks of using the original substance. So some more details about fentanyl. I think we know some of this already, but fentanyl is known for being extremely potent. So while it's very similar to while it's chemically similar to other opioids, it is more potent, and usually you'll see estimates somewhere between 30 to 50 times more potent than heroin and 80 to 100 times more potent than morphine. Fentanyl is something that's used both licitly and illicitly. And over here on the right, so illicit fentanyl is most commonly found in a white powder form, but it's also pressed into pills. So we'll see some examples of what pressed pills look like with fentanyl in them. And on the right here, you can see these are samples confiscated by the DEA of what heroin and fentanyl look like side by side. So when you see them side by side, it makes sense of how, not only for the similar effects, but for the similar appearance, fentanyl was able to sort of replace heroin. Sometimes fentanyl is known for having a little bit more of a brighter white color, where heroin has a little bit more of an off-white color. I don't know if you can tell that exactly from this photo, but that's part of what the reports are about, sort of maybe being able to tell the difference between the two. And we'll talk more about that in a minute as well. It's also important to note here that there are numerous fentanyl analogs. So fentanyl or fentanyls is sometimes used as a catch-all for all of the different fentanyl analogs, because very often we don't necessarily know which type of fentanyl is being used when someone is manufacturing it illicitly or when someone is using it. So other types of fentanyl that you may have heard of are things like carfentanil and acetylfentanyl, and then fentanyl derivatives, sufentanil and remifentanil. I think something important to note here about sort of the fentanyl analogs and fentanyl derivatives and NPS in general is part of what happens is as certain elements that are needed to create something like fentanyl in a laboratory get outlawed, the precursor elements, as those get outlawed or made harder to acquire, essentially what can happen is people will shift what they are actually using to make fentanyl, and either they'll find a new way to make fentanyl using slightly different chemicals, or they'll make a fentanyl analog, right? So you can tweak the chemical structure to come up with that. Looks like we lost audio for a second there, but we're back now. Okay. I mentioned that fentanyl is used illicitly, so there are medical uses. Fentanyl is a Schedule II substance, which means the government recognizes that it has medicinal value. And it was synthesized in the late 50s and first started being used in clinical settings in the 1960s. Generally, it's used to treat, it's usually used to manage pain. So this will often come in things like transdermal patches or tablets. And basically that allows the drug to move through fatty tissues and leads to a slower release and prolonged effects. So that's really how fentanyl is able to be used safely in medical settings. That's a large part of it. So it's used to treat things like chronic pain or severe acute pain, as well as it's part of epidurals that are given during childbirth. It's used as part of cancer treatment and heart surgery. So fentanyl really, in some ways did, especially when it first came along, it opened the door to new medical procedures and benefits that were not really available at the time. Things like heart surgery were made a lot easier because of fentanyl. So I think it's just important to sort of have this full picture of there being legitimate uses for fentanyl, that I think fentanyl is sort of treated as this demon drug and sort of all lumped in, so that people in a hospital might be worried about getting legitimate pain treatment. And so it's important that we recognize that there are legitimate uses for fentanyl as well. Fentanyl can be administered a number of different ways: intravenously, intramuscularly, orally, or those transdermal patches that I mentioned. You see some brand names on there as well. Part of what makes medical settings, looks like we've lost audio again. Is it just one person, or are other folks able to hear me still?
I can still hear you.
Okay.
I think some people are dropping off or losing audio connection.
Okay, great. There is a call-in number. Thanks for all those who are chiming in that they can hear me. There is a call-in number for those who are having trouble maybe with their computer audio. I find that usually works pretty well on WebEx. So the point here is just, in medical settings, the dosage is highly controlled and patients are under close monitoring to protect against adverse side effects. Very often when people are being administered fentanyl in a medical setting, they're usually connected to an IV that might even have naloxone available on drip, so that doctors can, in the moment, actually adjust how much fentanyl they have in their system. And if they find that their oxygen levels are getting too low, actually provide naloxone immediately to help offset the effects of some of the fentanyl, so that people are able to kind of safely have the medication administered to them. And here's just a note from the CDC. Most fentanyl-related harm, overdose, and death in the U.S. are linked to illegally made fentanyl. So as I mentioned, those kind of NPS, or those chemicals that are created in laboratories, it is the same drug. They're creating a chemical alternative. It is the same chemical that they're creating in the laboratory that's made when that exists when doctors use it. The big difference is not being able to have as much control over the dose, not having close monitoring, not knowing how much fentanyl someone's taking when they're using an illicit version of it. I'll also just note there was briefly a period of diversion of prescription fentanyl that occurred, but that's never really been a major contributor to the supply of fentanyl in the illicit market. So that's not really where our efforts need to be focused. Effects and symptoms. So I already mentioned briefly that the effects of fentanyl very closely mirror opioids. So if you're familiar with what prescription opioids and pain relievers do, or what heroin does, you'll see a lot of very common symptoms between all of them because they are all opioids. Pain relief, euphoria, can cause nausea or constipation, sedation, drowsiness, and depressed breathing. Where fentanyl differs is it causes more significantly these final two symptoms. So bradycardia, which means a slowed heart rate, and chest wall rigidity, or what's sometimes referred to as wooden chest syndrome. And that actually kind of creates some additional medical complications that can make delivering CPR very complicated. And so fentanyl is a little bit more dangerous than other opioids, not only for its potency, but also because of some of those added effects that can kind of complicate the experience of the overdose that someone might be having. I did just want to note someone else in here mentioned something about the effects of fentanyl, that they know that it was used over 20 years ago for weight loss on an Indian reservation they worked at, and that there were people who claimed they wanted for that purpose and then accidentally overdosed. I haven't heard much about fentanyl or opioids in general being used as a form of weight loss, but what I will say is that substances in general, because they tend to sort of provide such intense, powerful feelings of euphoria or whatever it might be, they are not necessarily appetite stimulants, and definitely can lead people to missing meals. And that actually is one of the things that can cause additional health problems, is just people being malnourished. So malnourishment, for instance, is one potential risk factor for an overdose death. So people are more likely to overdose if they're malnourished. And if you think about, alcohol is another common example. It's sort of, the difference for your body of having a drink on an empty stomach versus having a meal while you have a drink. So here we are, we're at a poll question. So again, I'd like to get some of your input and feedback, because I am really curious what your experience of the people you've worked with, what the people you've worked with, what their experience is and what you've heard from them about fentanyl. So Rebecca, you can go ahead and pull up the poll. You can see the poll question here on the screen, but I'm going to go ahead and read it as well. So of the people who have used fentanyl, both personally and professionally, how many did so intentionally? None. Everyone I know used it unintentionally, meaning they didn't mean to use fentanyl, but they ended up using it. 1 to 25% used intentionally, 26 to 50% used it intentionally, 51 to 99% used it intentionally, or all. Everyone I know who has used fentanyl did so intentionally. And if you don't know, that's okay. You can just sort of either leave it blank or give a guess of what you think might be the case from some of the people you've worked with. So we have about 20 to 30 more seconds for people to respond. So take a second, come on back to the poll. You should see it over there on the right side of your screen. And the poll will close in a few more seconds. Great, so the poll is closed now, and Becca, if you could go ahead and pull up the poll results on the right side so we can see those. Okay, so looking at these results, it looks like the most common response that people gave was about 1 to 25% used it intentionally, meaning some of the people we know were seeking out fentanyl. Some of the people, it may have been a few people, may have been a good chunk, but you also see, and this is interesting to me, that the people who are 26 to 50%, 51 to 99%, and everyone you all know who used fentanyl did so intentionally. That's really interesting to me because I think that's actually not especially common. You can see the breakdown is that actually most people, it seems like we're finding that the people they've talked to, they know at least some people who have used it intentionally. And so that's something that may be starting to develop now, is that there is, because of sort of the known effects of fentanyl, that people might be starting to use it more intentionally. But also significantly, 33 of the people who responded to the poll, so about 10% of the people who responded to the poll, noted that the people who used fentanyl did not do it intentionally, right? So people who were thinking that they were using some other substance, but actually ended up getting fentanyl when they didn't intend to. And so I think that's an especially concerning area for us, because those are people who are at a really heightened risk if they're not expecting to get fentanyl, and that they end up with it in their drugs anyway. I'll just open the chat. So yes, if anybody has any other thoughts sort of on what they're seeing in these numbers, or what they think might be interesting about that. Like I mentioned, I am pretty surprised to hear that there are so many of you who have experience working with people who are intentionally seeking it out. I'll go ahead and move us on to the next slide. So when it comes to who is using fentanyl, broadly speaking, to kind of put it into some different categories here, I would say, that people can kind of fit into these different categories. So there are people who use it unintentionally. And as I was just saying, those are people who may be purchasing a substance. Most commonly, it's going to be people who are looking to use heroin, who end up with something that actually is contains fentanyl or is entirely fentanyl. People who know it may be in their drugs, but are willing to take the risk. So those are people who kind of know, hey, I might be a regular heroin user. I know that more and more fentanyl is out there, but I'm not willing to stop. I'm not willing to maybe switch to methadone or buprenorphine. So I'm going to keep using what might have fentanyl in it. And then people who actually go and seek it out. And so one of the people actually here in the chat just mentioned some of my clients first used unintentionally, then started seeking it out. Another person saying, in my area, there's very little actual heroin. Most of my parents actually use fentanyl test strips to make sure fentanyl is present, to know whether they're not getting some non-psychoactive powder. And so it is, I think this kind of speaks to part of what might be happening, is that what people do know about fentanyl, especially for people who might be dependent on opioids, for people experiencing withdrawal symptoms when they're not able to use opioids, is that, and I think this is really, maybe the people who are willing to take the risk and the people who seek it out, is that they're probably seeking it out because they know that it'll be effective at essentially eliminating their withdrawal symptoms or providing some sort of high that they might be seeking out. Whereas, if it doesn't have fentanyl in it, at this point, there might be skepticism that it could be actually effective at all, or contain any opioids. Someone's asking here, is fentanyl more accessible than heroin or cocaine? I think right now in our country, where we're at in terms of fentanyl's availability, is that we're actually seeing that fentanyl is present in, depending on where you are in the country, the majority of samples that are purchased as heroin. So it's not that I would say that fentanyl is more accessible than heroin or cocaine, because very often, in most drug markets, people aren't going out saying, I would like to buy some fentanyl, but they are getting fentanyl when they are trying to purchase heroin. and they can sort of expect that. And I think, again, that's sort of those people in that middle group who know it might be in there, but they're willing to take the risk. And so I think, as counselors, as treatment providers, as people who serve people who use drugs, it's really a question of, if people are seeking it out or if people are willing to take that risk, we can kind of ask ourselves what might be our role in that case. How do we work with people who are sort of in that position, as well as working with the people who are using it unintentionally, who just might not be aware that it's out there or that it might be present in their substances. So moving on in the discussion here. So some of the perceptions of fentanyl among people who use drugs. So this is actually based on a study among people who inject drugs in Massachusetts that was done a few years ago. And for me, kind of what the theme here is, if we want to know about drugs, we really should be starting with the people who use drugs, right? That very often the people who use drugs are the ones who know the most, who have the best ideas, who kind of are a little bit ahead of the curve. And this is definitely one of the shortcomings of our current approach to drug policy and kind of creating a strategy to sort of address the overdose crisis is when it comes to understanding and identifying the contents of drugs, we're pretty far behind the curve. So our overdose statistics are usually, depending on where you are, 6 to 18 months behind schedules. So, an overdose death that occurs today may not be fully investigated for several months, and we might not have compiled statistics on it for over a year. So it's very hard to know what's happening right now in the drug supply. But when we actually talk to people who use drugs, very often they have information that might not be widely available yet. So again, just emphasizing why it's so important to be talking to people about this. But so some of the takeaways that the researchers found from talking to this population and conducting this study was that they noted in 2013 the heroin supply changed, including an increase in fentanyl-adulterated or substituted heroin, or FASH. And I actually like that acronym because it acknowledges both that there is heroin that has fentanyl in it, which is fentanyl-adulterated, or substituted heroin, meaning fentanyl as a substitute for heroin. Usually that means that the fentanyl is cut up with other substances in order to sort of make it similar in weight and size to heroin, but there is no actual heroin contained in it. And that's pretty common in the supply of drugs that have been confiscated or found. Most fentanyl that is confiscated is just fentanyl. And that could be because it hasn't been mixed into drugs yet, but most confiscated fentanyl is pure fentanyl. And then the next most common are fentanyl and heroin combinations. There is, and we'll talk a little bit more about this in a second, there is some fentanyl and cocaine, excuse me. There is some fentanyl and cocaine mixes out there, and there are some fentanyl and methamphetamine mixes out there. But by far the most common are fentanyl by itself and fentanyl mixed with heroin. Some other things they talk to people about are, are you able to distinguish between heroin and fentanyl? And there's sort of some mixed responses about this, but in general, these are some of the takeaways they found, is that there are sort of embodied effects. There are people who sort of can say, there's a change in the way that I feel, whether it's how intense the high is, what parts of their body they might feel the effects from the drug in, but that when they actually get high from it, they can tell this has fentanyl in it. Other things that people mentioned or note are being able to distinguish based on the taste of it, of the substance, what color the powder is, which is one of the examples I mentioned before, and what the solution looks like. So when you mix up the drug and you cook it with water for injection purposes, that you can actually tell a difference based on what the solution you create, what that looks like. So there's definitely some debate about this. There's some folks who say, I had no idea there was fentanyl in this when I was using it. And there's other people who kind of think that they can tell. And I think either way, caution is is advisable in either situation. Even if you don't know, certainly you want to be careful. But if you do know, still a lot of the same principles of safety and harm reduction can apply here, of sort of taking your time and being careful with the solution that you're using. There's some disagreement over whether fentanyl or heroin produces a better rush, with some reporting that fentanyl provides a more intense rush. So I want to just like pause on this point for a second, because this is really significant because, and this is something that's been sort of reported as well, and is related to the next point, which is, has a shorter duration than heroin, right? So people report, a return of withdrawal symptoms more quickly after using fentanyl when compared to heroin. So this is something that's sort of true when you compare things like the route of administration. So when you inject heroin versus snorting heroin, part of the danger of injecting versus snorting is that you get a more concentrated amount of the drug in your system more quickly. So you get a higher effect, and the effects come on more quickly. That puts people at a higher risk for overdose. But then on the other side of that is when the effects wear off more quickly and the withdrawal symptoms come back sooner, it also makes you more likely to use again. So it makes people more prone to kind of ongoing use and developing dependence if there's a shorter duration. And so both of those things are generally considered to be true about fentanyl, is that it does provide this intense rush right away, but that the effects can wear off a little bit more quickly. And so again, not just for its potency, but because of sort of the way that fentanyl acts in people's system, this does create some additional concerns or some additional things to be mindful of when people are using it. I'm just looking through the chat, just a couple of points here. Just interesting things, that there are people who we know who are being prescribed fentanyl, probably for legitimate pain reasons. And that one person noting very little heroin in my area. And I think that is becoming more and more common. So I'm based in Chicago, and most commonly the programs up here are telling people if you're purchasing heroin, you should assume that it has fentanyl in it, because it is over 50. Again, as I said, over 50% of what is purchased as heroin is this actual FASH substance, as they refer to it here. It's either fentanyl-adulterated or substituted heroin. And then last, I just wanted to pull out this quotation from one of the research participants, a person named Julie, who said, "I don't like fentanyl. I don't like it. I try to stay away from it. I try to. But when you're sick and you need that fix, you'll take anything." So Julie really, I think this quote just sort of embodies that middle group that we were talking about on the last slide, of people who know that it's probably out there, but are sort of willing to take that risk in order to manage, the sickness that they're dealing with, whether it's withdrawal symptoms or if it's just, an urge to use. That is sort of an overriding concern. And I think when you talk to a lot of people who've struggled specifically, I would say, with opioid dependence over the years, this is something that I think is not uncommon, is people who might want to stop, who might not want to keep using something, but kind of get pulled back to it because those withdrawal symptoms are so unpleasant. I remember talking to one person, this is years ago now, but he said, the only thing worse than, how I feel when I'm using is how sick I feel when I'm not using. So we've started to get into this already, so I appreciate the people who are chiming in the comments as well. When you are talking to people in your community or in your programs, what are you hearing about fentanyl? Are people kind of talking openly about it in groups? Is it a topic that gets addressed? Anything else you want to add in the chat here? These are questions for you all as the audience. Some other questions that I threw up here are, how do you engage people when you talk about it? I think it can be very easy to default to some of the language that's out there. You'll note in my description of fentanyl up until this point, you haven't seen any skull and crossbones. You haven't seen, I haven't had to say the killer drug or the deadly drug to talk about the fact that it's more potent, that it's, that it increases people's risk of overdose when they're using it. But people saying that they're hearing that it's super, super dangerous and deadly. More intense rush, so that's something that we've been hearing. Someone notes they've been hearing from their clients, and that it's expected to have it in any heroin that's bought. So that, I mean, I think that's really an important detail, is that that information seems to, hopefully, I mean, I think it's really important that people who are using drugs have that information in the community, that they know there's a good chance that when they get heroin, that it's going to have fentanyl. I think that's a really actually positive step for us to be able to see that. One person saying we have more fentanyl available in our area than any other drug. And someone saying, you know, positive result opens the door to have that discussion. And talk a little bit more about drug testing in a second as well. So it's interesting, fentanyl is the main drug in the street and everyone is doing it. Everything has fentanyl in it. And higher chances of an overdose while mixed with alcohol and medications. I mean, I think if we're hearing, and that's very true, right? So if we're mixing fentanyl with really any other drugs, but especially things like alcohol, medications, like, you know, especially things like benzodiazepines or other opioid medications, and that significantly increases someone's risk for an overdose. So it's actually great that some of this messaging is out in your communities already. I think the other question is, you know, how do you engage with people when you talk about it? Is this the kind of thing where we're sort of just like throwing information at people and saying, did you hear how bad this is? Or is it the kind of thing where we're trying to open the door to a conversation, as someone used that expression, which I really like, is sort of saying, are people open to talking to us about it? Do you feel like people are willing to share about their experiences? Someone specifically asked, is there an explanation why with fentanyl in the system we need to wait longer than 48 hours before we can start induce patient with Suboxone? With heroin is about 12 hours before patient goes to withdrawal. I actually haven't heard that, so I can't really speak to that specifically. For those of you who are talking, about fentanyl with your clients or participants, what have you noticed are some of the benefits of having these conversations? So someone noting in the chat that fentanyl, because it is fat soluble, does take longer to get out of the system. So that might be related to the Suboxone question. Someone saying, I mostly ask questions because I don't know much about it. I've been more educated recently and specifically seeing DCF cases regarding substance-exposed newborns testing positive for fentanyl. People feel less judged and more likely to come to you. So it's better for relationships when we can have these conversations. And people are more aware of the danger. So greater awareness, greater connection, opening the door. You know, so, and then someone else saying, a lot of the people you come into contact with want to minimize their use and the effects. And I think that's the challenge, right? Is we've really, in many ways, set people up to not have conversations about their substance use. Even with people who are supposed to, right, in working in a substance use treatment program, we're supposed to really be there to help them out. And so that is really the challenge for all of you working in substance use treatment programs about how to overcome this. Is, you know, how do we create an environment where people feel safe sharing that they're engaged in an illegal activity, that they're engaged in something that might get them in trouble with their job, kicked out of a treatment program, you know, in trouble with probation or parole, whatever it might be. There's a lot of potential consequences, right, in continuing to use illicit opioids. And so it does take a lot of work, I think, to build the trust and relationship to a place where you can have open conversations about things like fentanyl use or fentanyl exposure. But I think what we're hearing from some of the people in this chat are, when we can actually have those conversations, there are some benefits in terms of removing judgment, letting people know that, you know, I'm not here to tell you to talk to you about fentanyl because I'm just going to insist that you stop and try to figure out how to force you to quit. The point is that we know when people have an opportunity to sort of discuss these things, that they're better informed, that they're more likely to make safer choices, and that it really importantly, that they feel like they have someone who they can talk to safely about it, right? If you're a person who someone can talk to when they're choosing to continue using, you're hopefully also going to be the person that they can come to and feel safe with when they're ready to stop. And so I think something else for us to consider is, you know, when we hear information about fentanyl, do we talk to our clients about it? Or do they tell us about it, right? Do people come in and say, I heard there's a bad batch going around on, you know, the west side of the city right now. You know, everybody should sort of keep an eye out for that. Watch out because there's bad stuff out there right now. Is that information that's being shared amongst clients or that we're sharing ourselves? And we'll kind of come back to that question a little bit later too, something to think about. So I mentioned fentanyl most commonly found in powdered form, but it does also get pressed into pills. And I feel like this is something where hopefully we're starting to get a little bit more awareness and education about. But because, you know, fentanyl is thought of as a powder substance, I think people fail to recognize that it actually can be pressed into substances and pressed into pills. So on the left, you see 3 different versions of substances that were confiscated that were in the top and bottom are things that were sold as OxyContin but are actually fentanyl, and the middle one is Xanax or benzodiazepine that was contaminated with fentanyl. So, you know, again, when we talk about kind of that first category, the people who are using that unintentionally, there's certainly people who might be seeking out pills or even seeking out opioids like OxyContin who may not be aware of the presence of fentanyl in their drug supply. So I think especially, you know, people who might be dismissive of information about, that they get about fentanyl, it's important to say that even if you are even if you're not purchasing heroin, if you're purchasing pills on the street, if it's not coming from a doctor, you really don't know what's in it. And it's much easier these days for someone to make something with fentanyl in it than it was in previous years. So the other things I wanted to just mention here, so we have data from the DEA which does show that fentanyl is increasingly present in the illicit drug supply. So we're not only seeing the increase in terms of deaths, but we're also seeing the increase in terms of the supply. Fentanyl is, as we were saying before, and some of the people noticed, or people have noticed from their conversations with people, is fentanyl is becoming more and more common, and we have a lot of data that basically backs up that notion. I mentioned before, most commonly fentanyl is mixed with heroin, but as you can see, it can be mixed with other substances. And because it's a white powder, it's pretty easy to add to other drugs. So the next thing I want to talk about is something that's sometimes referred to as the 4th wave. So at the beginning, we talked about sort of the 3 waves of the overdose crisis. What people are starting to refer to now as the 4th wave is overdose deaths involving stimulants. And in particular, as I noted before in the chart, we're starting to see the uptick in methamphetamine and cocaine involved overdose deaths. And so that's what people are sort of saying, you know, might be this 4th wave upcoming and something for us to be extremely mindful of. And just as I was saying with people who may think that information about fentanyl isn't relevant to them because, oh, well, I only buy pills, and so, you know, fentanyl I don't really need to worry about. Same thing with people who use cocaine and methamphetamine. I think what we know, again, this is an example of where the information is so delayed. So when substances are confiscated from the street and when they finally get into drug testing laboratories at the state level or at law enforcement level, by the time those results and information get back out to the community, it's often way beyond the time when that substance is still available to people on the street. And so there's a real challenge there in how do we get real-time information out to people about the presence of fentanyl in the drug supply. Drug screening results show an increase in people mixing fentanyl and stimulants like cocaine and methamphetamine. So what I'll caution against here is when you look at kind of, and this is from a study that they did where they were looking at hospital drug screening results, But what I'll caution against here is drug screening results don't tell us that people took cocaine or methamphetamine that was contaminated with fentanyl. What it tells us is that more people have both cocaine and fentanyl in their system, or methamphetamine and fentanyl in their system, but it doesn't tell us exactly how they took it. And again, this is where our information and reporting is pretty delayed. What is generally the consensus among public health experts right now is that the trend is really being driven by polysubstance use. So people who are intentionally mixing cocaine with heroin or with fentanyl, or intentionally mixing methamphetamine with heroin or fentanyl. And again, I think part of what, if you've had conversations with people, you might have heard different explanations of why that's happening. And oftentimes, someone might kind of use cocaine or methamphetamine throughout the evening and then want to be able to fall asleep at night, so they use heroin to kind of help them fall asleep, or they might mix the two together for speedball, or they might kind of alternate throughout the night. But either way, there are reasons and patterns in why people might mix the two of them together. Someone's here saying that we were able to identify most fentanyl use prior to drug screens due to cocaine positive drug screen results. So patients denied cocaine, but admitted to fentanyl use. And I think, honestly, people, again, like we're talking a little bit about like what people are willing to share with us and not. I think it's really interesting to think about what substances people are and aren't willing to talk about. Because I do think this can go both ways. So it's interesting to hear this comment from the audience, because there are certainly people who might feel more comfortable disclosing cocaine use at this point as opposed to disclosing heroin use. And part of that might just come from societal acceptance and kind of social attitudes toward these substances. But opioids in recent years have really been seriously demonized as being significantly different. And I know I've facilitated groups where attention can sort of arise between people who use different substances. Right, so someone who has an alcohol use disorder may say, well, sure, I have a problem with my alcohol use, but I'm not like someone who's using heroin. I'm not like, an addict or a junkie. You hear sort of stigmatizing language tied up in those comments. And it's interesting how this can happen, is that people have very different attitudes towards different substances, and they might feel more comfortable talking about some substances than others. I think fentanyl also, there is, some instance, so here's what I will say is, while the public health experts tend to agree that fentanyl is, that the trend is being driven by polysubstance use, fentanyl certainly is cut into stimulants like cocaine and methamphetamine. I mentioned it's much less common than it being cut into heroin, but we have, across the country at this point, found samples of cocaine and methamphetamine with fentanyl in it. And whether that's happening because of accidental cross-contamination or intentionally cutting is a little bit hard to say. But part of the added risk here is, as I was saying before, there is this added overdose risk when you're mixing stimulants and opioids. But especially for someone who is a primary stimulant user, someone who we would consider to be opioid naive, there's an even greater risk of overdose there, because if someone has absolutely no tolerance to opioids, no experience using opioids, that's something that could cause really significant effects from the use of opioids. And so something that we really want to be able to talk to people, even if they are primarily stimulant users, about is, you might be a primary stimulant user, but if you're around with friends and they offer you heroin, if it's available, is it something that you might use sometimes? Or if they don't feel comfortable talking about that, or if that just doesn't apply to them, being able to say there is a chance at this point that cocaine or methamphetamine you buy might actually have some fentanyl in it. And then just a couple notes here. So in my opinion, most of the clients being drug tested and positive for fentanyl don't even know what it is. So it may have been mixed with the cocaine or methamphetamine they knew they were ingesting. There is, I think, still a large number of people who we might be working with who there actually is this big gray area for them, where a gap in knowledge where they might not know or be aware of the presence of fentanyl or how common it is. Someone here noting the idea of fentanyl being sprayed on marijuana. As of yet, I haven't heard any substantiated reports of fentanyl contaminating marijuana. Where we have evidence of, from drug tracking services and from, DEA, law enforcement, public health data, it basically all points to fentanyl existing by itself or with heroin, or in some cases in cocaine and methamphetamine, but as of yet, no evidence of marijuana contamination. So I think if people are sharing that information, clients are sharing that information in group, people can sort of say what they have heard or what they think might be the case, but I would caution anybody against sharing that information because there's not really hard evidence to substantiate it at this point. I'll just, you know what, it's 10 o'clock, so I'm gonna pause, or sorry, it's 11 o'clock by you, I'm on Central Time. I'm gonna pause here. If there's any other questions, we can answer them now. Otherwise, we'll take a 5-minute break.
Yes, that's correct. We'll take a 5-minute break.
I'll just note here as a final note on cannabis, somebody shared fentanyl's combustion point is much lower than cannabis. Smoking it would destroy it when it's put to a flame. Definitely no substantiated evidence for fentanyl contaminated cannabis. So even if it were present, which we really have no evidence of that at this point, but even if it were to be present in cannabis, that you wouldn't really get the effects of it from using cannabis. So we'll pause there and we'll take a 5-minute break, and I will chat with you all very soon.
All right, everyone, this will start our 5-minute break. We will be back at 11:06. Hello, everyone, and welcome back to today's webinar, Understanding Fentanyl. Mr. Kowalsky, if you are ready, I will turn the presentation back over to you.
I'm ready to go. Thanks, Becca. Okay, didn't see any questions come into the chat, but again, feel free to use that. We have talked a little bit, a few people have mentioned drug screening. I will just, as a quick aside, I want to just let you know, I come from a harm reductions perspective. So personally, I don't believe that we should be engaging in compulsory or mandatory urine drug screening in substance use treatment programs. In fact, there are definitely programs out there that do not provide or do not offer any substance use urine drug screens. They don't do compulsory or mandatory. And where it is available in some of those harm reduction oriented programs, it would be available for people who would request it. So for instance, they might want to produce a drug-free sample to be able to demonstrate to family or friends as a measure of accountability, or they might be going for a job interview and they want to know, okay, if I take a drug screen for this job, I'm going to be able to pass it. In general, my perspective is that the harms that come from screening people's urine, the harms outweigh the benefits in this situation. And I think about times when I was working in a treatment program and I would watch someone pee into a cup 5 times before I would sit down for my first counseling session with them. And I just think about, and I felt in those moments, how is this setting up our relationship dynamic as a starting point? So, someone in the chat did mention, and this is an example of the benefits, is that, well, a positive screen results showing someone that they have fentanyl, especially someone who didn't think they were using fentanyl, can really open the door to this conversation. And so I would just push us all to try to think of other ways to open the door as well. If you use drug screening in your programs, I know oftentimes counselors don't necessarily have a say in terms of that policy, but I do think it's something that as counselors you can bring up. Program administrators, managers, this is something you can be talking about and really considering, what is the benefit that we're getting out of this? And is there something to be said for creating a relationship that's built on trust that, if people want to share that information with us, that they are continuing to use or that they have returned to use, that's really their information to share. And people should have a right to kind of give us their own stories on their own timeline. So anyway, I could kind of go on about this, but I do just want to set that up as a kind of as a preface to this discussion about urine drug screening for fentanyl consumption. So some key points to know about drug screening when it's related to fentanyl is that some forms of urine screening do not detect fentanyl. So you see down there the Desmond et al. Study that's referenced. So that was actually based in Baltimore, but they were looking at on-site urine drug screening that was done by a hospital. And what they found was something like over 80% of the patients had used fentanyl, but only 25% of the patients had positive test results for opioids. The hospital's opioid screen essentially was missing that a lot of these people were using fentanyl. And so unless, in a lot of cases, unless you're testing specifically for fentanyl, in the screens that you're using, you might actually be missing it. And so the results really suggested that fentanyl, when it was being used by itself and not in combination with heroin, was from our fentanyl consumption, or from our fentanyl urine drug screens related to fentanyl consumption. Also, unless use is chronic, your analysis may not detect fentanyl. So if it's a one-time use, opioids in general tend to have a pretty short half-life, so that can alter the results. And it can take 10 to 15 days after. I think someone had sort of asked about that. When use is more chronic or ongoing, that fentanyl might still be in someone's system. Also important to note that false positives and incorrect results do occur. So I think we should leave space for that in our conversations with people. to sort of acknowledge it. It's okay to sort of take that perspective. Someone's saying audio is breaking up. Let's see. Let's sort of adjust here. And then again, if you are doing urine drug screenings, how is that information presented? And then, when it includes fentanyl, how do we talk to people about that? I think those are all really important things to sort of consider as it relates to urine drug screening. I know that there are programs that when people come back for a positive drug screen, they actually force people to disclose that information in a group or to kind of other people. And I think that, again, can set up a really harmful dynamic with the people who we're trying to build trusting and meaningful relationships with. So we talked a little bit about kind of this theory that's floating out there that there might be the myth that, that there might be fentanyl in marijuana. I think probably the most common myth that's out there about fentanyl, and it's really important for us to dispel, I would say, especially when we're talking to community members, first responders. I know some of us have people who are first responders who might be in our lives, their family and friends, or just out in the community. As substance use treatment providers, you're probably considered, you've probably got some, contact with the community as well and kind of seen as a trusted resource. So really important for us to be able to emphasize that skin contact with fentanyl is not deadly, right? So skin contact alone does not cause an overdose. If you want to get the effects of fentanyl, as with other drugs, you would have to snort it or smoke it or inject it. You have to put it in your body in some reason, right? There's a reason that, the people who are using opioids and fentanyl are using needles, are snorting it, because that's how they actually get the effects from it. And so what you see in this image, this is Chad Sabora, who filmed a video, and I have the link in the references if you're curious, but and basically what he's showing is you can hold fentanyl in your hand, and what he does in the video is he actually takes a sample of the fentanyl, tests it, shows the fentanyl test strip that this is actually fentanyl, and then he puts it in his hand. And he holds it, he doesn't get high from it, he doesn't overdose from it. And it's really just to make this point that just skin exposure alone is not going to cause you to overdose from fentanyl. I think part of where this concern or this myth comes from is the fact that fentanyl medicinally is available transdermally, right? There is a patch, but that's very specific technology that was designed to be able to allow for skin absorption. Someone asked here, will skin contact cause a positive drug test or urinalysis? No, skin contact alone wouldn't cause positive urinalysis. You'd actually have to ingest it. Sufficient protection for first responders includes just the use of nitrile gloves. So if you are handling or managing nitrile gloves or handling fentanyl, really important that you wear gloves, but that's sufficient. So I've actually been to law enforcement conferences where there are people with tables that are set up where they have chemicals that you can spray on fentanyl to deactivate it, or they have hazmat suits that people can wear. All of that is really just over the top, things that are completely unnecessary. If anything, if people want an extra layer of protection, they can wear a face mask, basic N95 or KN95. And so I think, today with COVID and everything, a lot of people, first responders especially, are wearing masks when they go into situations anyway. So between a mask and nitrile gloves, people are sufficiently protected. If you do come into contact with fentanyl, you have skin exposure, it is enough to just wash your hands with soap and water following skin contact. But you shouldn't use alcohol-based hand sanitizers. Those can actually increase absorption. So really just basic soap and water is sufficient there. So I'm looking here, someone mentioned in the chat that they've been taught that carfentanil can be dangerous if handled, and how you can tell between the two. I think that's kind of a real challenge there is, when it comes to fentanyl analogs, they will present and look very similar to to fentanyl. The powders are all very similar. The analogs are all very similar in appearance to each other. There might be some sort of difference there in terms of effects, like the potency of it, but it's going to be really hard to tell just from looking at it. The other citation here, and part of where this information about hand washing and nitrile gloves comes from, is from the American College of Medical Toxicology. And so they put out a statement. This myth has been floating around for a long time. You see, their statement was back in 2017. They put this information out there. They were telling people at the time, essentially the main thing to know is that, while there's stories out there about emergency responders having symptoms of an overdose or experiencing an overdose after skin residue, that when you look into those stories, the reported symptoms are not actually consistent with an opioid overdose. And basically those drugs are just not absorbed well enough through the skin to cause sickness from incidental or casual exposure. So that's the American College of Medical Toxicology, and again, that's in there. Someone in the chat notes that the symptoms are actually more consistent with panic attacks, and so that actually leads into some of kind of like the other things I wanted to say about this really dangerous myth that's out there. First, I think important to know, part of why this happens is I think these stories are, they're sensationalistic, they're really scary. If you hear from someone, oh, I heard about, a firefighter or a medic or a police officer who was in a room with fentanyl and they overdosed from it, that's really scary. And those stories spread very easily. So you see here this first point, stories about overdose caused by fentanyl exposure have been reported and shared widely through social media. It happens in local news as well that these stories get reported and shared out. Most recently, we saw this play out with a video circulated by the San Diego County Sheriff's Office, and that included body camera video where an officer fell backwards and was experiencing what he believed to be an opioid overdose. Officers rushed to his aid, gave him naloxone, and the video was sort of put out there as kind of a warning about fentanyl's presence in the drug supply. The problem is that a lot of public health experts looked at that video and said this person isn't having symptoms that are consistent with an opioid overdose. One person actually said absolutely nothing in that video is consistent with an opioid overdose. And so, some signs like when people are still conscious, when people are still talking, when they're, appear to be breathing, oftentimes, as someone mentioned, it seems to be more consistent with anxiety. And what I've heard referred to as a nocebo effect as opposed to a placebo effect. But basically, the nocebo effect is, people have been sharing these stories and these rumors in such a way where people think and they have such a fear of this drug that just being around it actually causes some symptoms of panic and anxiety to occur. And I did see one study, I don't have it referenced here, but if you're really curious, I'll happily pull the citation for you. But I believe that the number that they came up with was they were looking at the way that stories or misinformation about the overdose risk from casual fentanyl exposure were spread on Facebook. And they were saying that what happens is these stories come out, as happened with the San Diego County Sheriff, and they get shared over and over and over on social media sites like Facebook. And then when the retraction comes out, when the correction comes out, that those stories don't have nearly the same level of traction, and that the misinformation is actually 15 times more likely to be shared when compared to the information that's actually correcting the mistake. So that's part of how this myth is out there and how it continues to spread. And basically, the real danger, not only in terms of, people being scared, people having panic attacks, that's not good. People using naloxone when they don't need to, that's not great either. But really most importantly, I think, is that there's a fear of exposure that could cause people to delay their response, right? If a first responder hears, oh, there's fentanyl in that room, and they think, well, if I go in there, I'm risking my own life, when really they're not in any danger just from being in the same room or even touching the supply. they might cause them to delay their response. And as we know, with overdose response, every second, every minute really makes a big difference. So this was sort of, I think, one of the questions that came up. Why are we seeing more fentanyl? And so Ben Westhoff wrote this great book called Fentanyl, Inc. So if you're interested in sort of more of the historical development around fentanyl, the supply chains, the manufacturing chains, how fentanyl came to be and how it gets here, you can check out that book. But what he said in an interview about why we're seeing more fentanyl is it can all be traced back to profit motive, right? So it's cheaper to make it, it's cheaper to supply it. We often think about the ratio of fentanyl's potency in terms of what that means for the individual user, right? If it's 30 to 50 times more potent than heroin, that means a much smaller amount can cause you to get really high or even overdose. What we don't think about is on the supply side, the same is true, right? If fentanyl is 30 times more potent than heroin, that means, for every 30 kilos of heroin that I need to move, I only need to move 1 kilo of fentanyl. So it's a much smaller amount of drug that I need to move around, easier to avoid detection, easier to sort of replace, and very inexpensive to make, not only because of transporting, but also, as I mentioned, because it's a completely synthetic opioid. You don't need to have fields of poppies growing to be able to manufacture this opioid. You can do it completely in labs using precursor chemicals and elements. I asked at the beginning the question about, are people intentionally seeking it out? And what's interesting, part of how fentanyl sort of surprised us or snuck up on us in a way is as recently as, I think it was something like DEA does an annual drug report every year, but as recently as 2015, the DEA was basically saying that they didn't think that fentanyl was going to take over a significant portion of the opioid market. That was their prediction in 2015. Just a year later is sort of when we saw the shift to more fentanyl-involved overdose deaths than heroin involved. But basically what they were saying is fentanyl's got this short high mortality rate, and it's just not really appealing to a lot of opioid users who want the longer lasting high that comes from heroin and don't want the danger that comes from fentanyl. So they really thought that fentanyl wasn't going to take over the market because it just, looking at supply and demand, it just wasn't a more desirable product. The problem with the illicit market is that it's not really driven by what the customer wants when we're dealing with the black market. It's dealt with, it's really driven by what's made available to the customer, what's in the best interest of the people who are manufacturing and selling the drugs. And so they have really driven it. So, yeah, I think that's what a lot of it comes down to. So I want to also just note here, there's some unintended consequences that have happened as a result of our response to fentanyl so far. You saw when we looked at the 3 waves earlier that as the crackdown on pharmaceutical happens, there was a corresponding increase in heroin overdoses that kind of followed that. And so we've had a lot in our response to the overdose crisis up until this point, we've had a lot of focus on restricting the supply of prescription opioids. The problem is that didn't come with a similar focus on drastic expansion of access to treatment options, including things like methadone and buprenorphine. In many places, people struggle to have access to methadone and buprenorphine. They have to travel a long time to get to clinics or whatever it might be. It just might not be available at the treatment programs in their area. And so we have these really effective services and treatments for opioid use, but we didn't make those widely available at the same time as cracking down on the people who were already dependent on opioids, from the wider availability of prescription opioids earlier in the century and then in the late 90s. And so sometimes this is sort of compared to a balloon, where if you're holding a balloon and you squeeze it, the air doesn't go, if the balloon is tied, the air doesn't go out of the balloon, right? The air just moves to a different part of the balloon. And that's essentially what we saw happen with opioid users. The balloon is, in a sense, filled with opioid users. We squeeze the opioid users from the prescription opioid side of the balloon, and we move them sort of into the illicit market. So there was this increased demand for heroin. And now what we're seeing is we have this contaminated drug supply. As several people noted, they've heard that heroin is harder and harder for people to acquire, that more often they're getting fentanyl, even if they're seeking out heroin, and that the more potent opioids being used has led to an increase in overdose deaths. And then as an addition to all of that, that chronic pain patients have been harmed in the process. So we focus so much on restricting the supply of prescription opioids that people with legitimate pain conditions now have a lot more trouble getting access to the medications that have been beneficial to them in the past. I think it's important to acknowledge the harm that's been done to them as well. Sometimes you'll hear this expression, we can't arrest our way out of the problem, we can't arrest our way out of this crisis, and yet we still see a really heavy emphasis on using the criminal justice system as a way to try to address the overdose crisis and now trying to address fentanyl. So since 2011, over 40 states have proposed legislation to increase penalties for fentanyl, while 39 states have actually passed or enacted such legislation, and that includes Florida. So this is the case, even though we have evidence that shows that escalating criminal punishment is not associated with reductions in injection drug use. We have harsh penalties on the books already. It didn't stop fentanyl from coming around. And so now what we're doing is increasing the penalties with the hope that it will somehow deter fentanyl at this point, when it hasn't done that up until, it's not like the, opioids or illicit drugs were more legal before. The law enforcement approach has sort of been in place, the prohibition approach has been in place, and it hasn't prevented this crisis from really getting out of hand. So when you hear people say that we need to focus on public health, it really can't be followed by immediately escalating the penalties for specific types of drugs. And even our efforts to single out the people who might deal drugs are really misguided, because what our evidence shows is often the people who get caught up and charged with additional charges because they were selling drugs are often people who are using because they're trying to support their own use, or they're people who are sort of helping a friend purchase their drugs. And so, there's really limitations to that. And I put a couple things on here also because what's really sad about this is this has sort of been predicted for a long time. So the iron law of prohibition was a concept that was first mentioned in the mid-1980s. And then you see this quote here from Gary Henderson from 1988, who was writing in a piece about designer drugs at the time. And in his conclusion, what he said was, it is likely that as efforts to restrict the importation of natural products and prevent diversion of pharmaceuticals become more effective, the fentanyls and other synthetics will become increasingly important drugs of abuse. This is, over 30 years ago now, before the rise of the overdose crisis, before the rise of this third wave of synthetic opioids, people were sort of predicting and saying, if you crack down, and this is what the iron law of prohibition says as well, but basically, if you crack down on, the more harsh your punishment is for, certain types of drugs, the more potent the drug supply is going to be. That's really the essential part of the iron law of prohibition. And that's what we've seen is there's been heavier restrictions on prescription opioids, heavier restrictions on naturally derived or semi-synthetic drugs like heroin. And as that restriction has occurred, people have moved to synthetics like fentanyls. And this both explains the rise of fentanyl, but also, some of the rise of some of the other novel psychoactive substances. So what do we do about it? Someone in the chat earlier said drug education is so essential. And really that's so much of what it comes down to is you all doing the work to, raise awareness, to build education, to make sure this information is out in the community. That I think is really what makes the biggest difference. And so I think of, this image, I use the image of a person holding an umbrella is, the education, the tools, and the harm reduction resources that we make available to people, the treatment resources, the medication-assisted recovery resources, all of those are sort of the umbrella to protect people from the storm of substance use or of opioids that they might be in right now. Someone mentioning unconditional regard, education, and harm reduction programs. So I think that's part of what we're going to get into now. So as a starting point, these are kind of some broad talking points. So even if you only have a couple minutes to chat with someone about their opioid use or about fentanyl, I think this is especially important for people who are working on the intake and assessment side of things. Is really there's always opportunities to have these conversations with people. And so even if you have a few minutes, here's some key points to try to touch on with people. So the title here is Harm Reduction for Fentanyl. Yes, even fentanyl can be used in safer ways, right? Every substance can be used in safer or less safe ways. And so we should acknowledge that reality with the people we're working with. So the harm reduction strategies that work with other substances can be used with fentanyl. So a lot of the same ideas and practices or messages, you'll see them applied to fentanyl as well, and they work just the same. So in some ways, they're even more important. I think the most key thing to mention, we'll say a little bit more about this as well, but it does respond to naloxone in the event of an overdose, right? Even though fentanyl is a more potent opioid, it is an opioid. Naloxone is an opioid antagonist, and so it does prevent people from feeling the effects of an opioid. And so I think, here, the kind of message is, if anything, people might need an extra dose depending on how much of the fentanyl or what type of fentanyl they have in their system, but naloxone still works. That's one of the most important messages we can get out there. Tasting drugs, so especially, I know, due to COVID, due to a lot of kind of changing circumstances, people may have lost touch with dealers or had to find new sources. There have been interruptions in the drug market because of COVID. And so you may not be buying from someone who you're familiar with, or even if you are, if you've been buying from the same person for 10 years, they don't necessarily know that they're getting drugs that don't have fentanyl in it. So especially whenever you buy a new bag, tasting the drugs is one strategy. So that just means using a very small amount before to see what the effects are before putting more in your system. Similarly, start low and go slow. There's actually two ways that this gets used. One is related to starting with a lower dose and going slow in terms of adding on. And so that can always be applied whether it's a new supply or not, but also it's an injection practice that people use about, how far away they inject from down their arm, but also how quickly they inject a solution. So injecting more slowly also gives the opportunity to taste the drugs, but also makes it safer for people as well. Altering the route of administration, I mentioned this before, but snorting actually reduces someone's overdose risk. You can still overdose from snorting heroin or fentanyl, but the risk is reduced slightly by snorting instead of injecting. And then avoiding mixing drugs, so especially combining opioids with other opioids, alcohol, benzodiazepines, and stimulants. And then also really important to be aware of changes in tolerance. So people who have been dependent on opioids might sort of have what they know to be their kind of standard dose, and they want to go back to it. And if they have a break in use because they decided to try abstinence, or they were locked up, or had a drug test, or lost their dealer, whatever it might be, even stopping opioid use for a couple days can be enough. Can be enough to cause someone to lose their tolerance. So it's really important there that when people go back to using, again, that start low, go slow, tasting drugs. If you're using for the first time, and this is so hard, right? But if you're using for the first time, we want to really encourage people to use a very small amount. Someone here, mentioned the word that this can come across as feeling like it might be enabling. And I understand that's a very serious concern that a lot of people have. I'd like to start up by saying, in response to that, everyone who is worried about, well, do harm reduction practice enable people to use drugs? I will just start off by saying, you and I, if you're feeling that right now, listening to this webinar, we're coming from the same place. You and I both care about people who use drugs, and we don't want to see them get harmed. And if your concern is that you're going to enable people by providing them with added education, my pushback to that would be, I think people are more likely to make safer choices when they have accurate and useful information available to them. And, whether people will make the decision to use drugs ultimately is up to them. And as hard as we try, as much information as we provide, as much support, even if it's unconditional, loving regard and support, there are a lot of people who will choose to use drugs for one reason or another. And the most important thing we can do is make sure that if they are going to use drugs again, that they're informed. I personally don't feel like I have the power to decide whether or not someone's going to use drugs again. But the most that I can do is provide education, provide support, and offer to be someone who's willing to maintain a relationship with them regardless of their choice to use substances, and try to provide the best support that I can. Someone else here in the chat notes, another harm reduction strategy, and I have seen this mentioned for fentanyl before, is to dilute your substances more, essentially put more sterile water into your mix when you are mixing up a shot. And so they say this also can help with going low and slow, and that analogs like carfentanil have been used more safely this way. So if fentanyl, and this is actually, for people who are trying to use opioids, shave off the withdrawal symptoms, diluting your substance more is a really effective strategy, not only because it means you can get the effects you want, you can reduce your overdose risk, but it also stretches out the dollar that you're spending, right? So if you buy a bag for $10 that usually lasts you for, let's say a day, if that, but if you can stretch it out by diluting it more, all of a sudden your dollars go a little bit farther. You don't have to hustle as much. You don't have to spend as much. And so I think being able to have those types of conversations with people, again, it might feel really uncomfortable and it might feel really challenging. But if we want people to make safer choices, which I think we all do, but if we want people to make safer choices, we can't just assume they're going to make the safer choice for the reasons that we think of. Right? We have to have these conversations in really open and honest fashion so that people can sort of come to the realizations or come upon the reasons that make the most sense for them. Someone mentioned fentanyl testing strips, and so I just wanted to, I think it's important that we talk a little bit about fentanyl test strips, and they are becoming a little bit more common. The graphic you see here on the left is from a harm reduction organization up here in Illinois. And it just sort of illustrates a couple different ways of doing fentanyl testing using fentanyl test strips. I'll acknowledge there is some minor discrepancies depending on who you talk to, which organization you talk to, and how best to use the fentanyl test strip. How long you hold it in the solution, how much of a sample you need to use. I'm not going to get into all those details because I don't think that's especially relevant for the conversation we're having here. But in general, fentanyl test strips are the most commonly used method for checking to see if fentanyl is in the drug supply. It can be accessed in the community. It can be accessed by harm reduction programs. You can go and buy fentanyl test strips. In general, they're around $1 or so a piece. And there are other, methods that we have for testing, usually that involve laboratories and lots more expensive equipment. So that's part of the benefit of fentanyl test strips is that they are so inexpensive. For a while, SAMHSA had a prohibition on using federal funds and using their funds to purchase fentanyl test strips. There's a lot of pushback from providers about that who are essentially paying for these out of pocket. They're having to sort of fundraise or find other ways to pay for them. SAMHSA has now changed their position on that. So as of April of this year, SAMHSA will now allow federal grantees to use their funds to buy fentanyl test strips. They're still illegal in Florida, though, and that is related to drug paraphernalia laws. So something to keep in mind there is that this is a resource and a tool that might not necessarily be as widely available in Florida. Spectrometers, sometimes called mass spectrometers, there's a lot of kind of fancy equipment out there that are an alternative way to test illicit drugs for fentanyl. And those are not just held by large laboratories, but there actually are some community-based organizations that are offering drug tracking services. So people can sort of bring in a supply of drugs the same way they would to use a fentanyl test strip. They could bring in a supply of drugs, and within a few minutes, it would be able to detect the presence of fentanyls, or, in some cases, it can actually tell you if there's the presence of other similar analogs or different types of fentanyl. So there are some limitations, I'll acknowledge, to testing for fentanyl. So one, it detects the presence of fentanyl, not the amount. So it doesn't actually tell you very specific information about that. For that, you would need more advanced lab equipment. the accessibility of testing. So who actually has access to these services? As we mentioned, fentanyl test strips not being available in Florida at all. Who's able to get to the program, who's able to bring their supplies in, and even if they are able to get to those programs, are they trusting enough, or are they willing enough to participate in the programs that offer this service? There's a lot of people who are worried about the fact that the drugs that they're carrying are illegal, and even if you say, well, I'm from a drug checking service, or I'm from a harm reduction program, they might not trust someone to keep that information confidential, to not share that they have drugs, to say, okay, well, I have this baggie, or I have this little powder, I'm going to give you some, you're going to test it, and you're going to give it back to me, and I'm not going to get in trouble for that. That's understandably, because of everything else that's happening, very hard for people to believe. But actually, in Illinois, we do have a law on the books that basically says that anybody who's carrying small amounts of drugs or residue from drugs for the purposes of either accessing a drug checking service, or the people who are in a drug checking service, are actually protected by the law. So there are some legal channels that actually can sort of open the door to more drug checking services. And then when it comes to drug checking services, these are a couple more images I just wanted to share. This actually on the left is an example of a mass spectrometer that I took a picture of at a drug checking service up here in Chicago. So you can just see they were doing a testing demonstration that day. And I want to say what they're detecting there might be acetyl-fentanyl. I can't quite read what's on this particular picture, but they were just showing us the way that this can detect particular types of chemicals. And then on the right, you see a close-up of what the fentanyl test strips look like. So pretty basic, but basically, you mix a substance, you put the test strip into the substance, and then the number of lines that appear will tell you whether or not there's fentanyl present in the mixture. So what happens when people use fentanyl test strips, or what do they do with those results? So these are from a couple different studies that have been done on these over the past few years, but most participants who receive a fentanyl test strip will use them to test their drugs. So that's kind of an important barrier also, is that, these resources are being used by people when you give them out. That the people who get positive results, meaning a test positive for fentanyl, are more likely to alter their drug use behaviors with harm reduction strategies. So some of those, altered behaviors include things like either completely getting rid of their drugs, using less, using a smaller amount, using more slowly, using with someone else present so that they could call for help if needed, or having naloxone on hand. So again, going back to this idea of, what happens when we give people this information and this education is there's research and evidence to support that more education, more resources actually results in people making safer choices. And that, the other thing we see, and I think this is a really beautiful finding too, is when given fentanyl test strips, participants share them with friends who they think are at high risk for fentanyl exposure. This is something that's been true of harm reduction services and the harm reduction movement for a very long time, is that people who use drugs want to help other people who use drugs. And even people who are in recovery, I'm sure you've had people in your groups or in your individual sessions who say, you know what, I'm not using anymore, but I want to give back. I want to help other people who are struggling with addiction. And for some people, that takes the form of fellowship and participation in peer support. For some people, that takes the form of participating in harm reduction services and getting naloxone and fentanyl test strips out in their community. And so I just sort of want to acknowledge that, the people who have been affected by these issues are very often the ones who are really eager to be able to help and support others. The other thing that I've heard just more anecdotally from people who are using fentanyl test strips in their program is, part of the challenge is, well, we don't always have fentanyl test strips, so people might come around and look for them. And at this point, a lot of the programs are really operating from the assumption that if you're bringing it in for, to be tested for fentanyl, especially if it's heroin, it probably has fentanyl in it at this point. But more importantly, fentanyl test strips might actually be an engagement strategy. So especially someone who primarily snorts their drugs, or maybe hasn't ever accessed a harm reduction program before, just didn't think it was that important. If they hear this community-based organization or harm reduction program has fentanyl test strips, that might be something that gets them in the door and opens them up to all the other services that program might offer, whether it's vaccination or access to, safer substance use supplies. getting referred to medical treatment or substance use treatment, whatever it might be. Fentanyl test strips might be what opened the door to people. And so one more way to help get people connected to really valuable health-related services. I'm going to kind of provide a little more detail on some other overdose prevention tips, things that I've talked about before on other webinars but are always worth mentioning and reiterating here. First, never use alone. And that's because when you use alone, there's no one there to call for help. You want to stagger. If you're with someone else, it's best to stagger your use with the person you're with, right? So to not try to inject at or snort at the exact same time or, right after each other, because if you're both feeling the effect, if you're both overdosing, no one's going to be able to call for help. So wait a few minutes at least to determine how potent the substance is that you're using before trying to kind of shift and make it so the other person has their turn. Some barriers to using alone that I'm going to acknowledge. One is stigma. A close friend of mine who struggled with opioid use for a long time and is now he's now in a methadone program doing really great. So definitely a success story in that way. But I talked to him and I would ask him like, well, I know you've like kind of gone back and forth between using. Would you ever use with other people? And he's like, I don't want anyone to know that I'm using. Right? I don't want to share that with anyone. I want to do it completely by myself. I hate when I go back, right? And I think that's probably a message or a sentiment that we've heard shared by other people throughout the years. So stigma is real. And even for people who have been using for many years, it's just a part of themselves that they want to hide away from anybody else. Safety and trust is really key. Like it's one thing to overcome the stigma, but do you actually trust that the person who you're using with is going to stay around long enough to, if you fall out, is going to stay around long enough to either call for help or to make sure that you get the help that you need, is going to have the, their wits about them to be able to like administer naloxone, provide rescue breathing, do other things to help you in that moment. That is like a really big leap of faith that you have to take in another person. And then last, I'll just acknowledge COVID-19 has kind of driven isolation. And what we've seen is there's been a really significant spike in overdose. And I don't think it's fair to just attribute it to COVID-19, but there's been a spike in overdose since the start of the COVID-19 pandemic. And whether that is people using alone, less access to certain treatment resources that might have been available or not feeling as supported based on, like online resources, there's a lot of different explanations. I don't think we're totally going to understand it for some time. I do think the interruption of the drug supply and certainly being discouraged from being around other people are contributing factors, though, that should be taken into consideration. Some alternatives to using alone: notifying a nearby family member or friend. Again, got to overcome that stigma, but letting someone know, I'm going to be using. If you don't hear from me in 10 or 15 minutes, or if I'm in the other room, come check on me in this amount of time, that sort of thing. But also a really encouraging development are some of these call lines and smartphone applications. And things like, you can look up all these. I have the link here for Never Use Alone and the hotline number. I have some of these other resources listed in the references. But the Be Safe community, the Brave app, and the Canary app, all of these provide very similar services in slightly different ways. But more or less, there's someone on the phone or on the app who is aware that you are using and is able to contact either emergency medical services or, persons who you trust in the event that you actually experience an overdose. And someone here in the chat, I want to acknowledge this comment too. It's actually more difficult to work with those who use alone because they don't have a support system, right? This idea, it extends beyond the instant where they're at risk for an overdose, but I totally agree with this commenter who's saying, beyond just the moment of the overdose risk, it makes it really challenging to work with someone who doesn't have a support system. And I think all the more important that you all are there, that you do the work that you do, and that you're a trustworthy, safe person, that people can actually come to you and you are their support system, right? And I think taking this approach, being open and honest and having these conversations with people, that is definitely something that opens the door for folks and helps them feel a little bit safer, that helps them start to say, hey, there are people in the world that I can trust, and really creates the opportunity or enables them to start to build a support system. So you all can, by the choices you make, by the work that you do, you are people's support system and can be an important foundation for that. So someone else is adding as an additional safety measure, make sure your kids are being watched by someone who isn't using drugs. And I completely agree with that. I don't have a real focus. I think we've done other presentations where we talk a little bit more about kind of harm reduction and family issues, but that's a really great point. And just a quick story, I did a group one time where I was sort of introducing harm reduction to a substance use group counseling session. And one of the people came out of the session afterwards and she pulled me aside and she's like, you know what, James? When you first started talking about harm reduction, I was ready to just stop listening. I was like, this man's crazy. She just couldn't believe what was coming out of my mouth. She's like, but as you kept on going, I realized I was kind of using harm reduction even when I was in my addiction. And she actually gave the example. She said, when I knew that I was going to use, I never was around my kids. I would always get a babysitter. I would make sure they were taken care of first before going to use. And I think that's a really good example of a harm reduction strategy that people can employ, if they are still using drugs. I've mentioned naloxone already, but, carry and use naloxone. It's the opioid overdose antidote. It works on all opioids. And really anybody who's using illicit drugs, like we've talked about cocaine and methamphetamine, should have naloxone available at this point and be trained on how to use it. And then acknowledging some of the limitations of naloxone. You can't self-administer. That's why it's so important to not use alone. It only works on opioids, so it's not going to counteract the effects of the cocaine or methamphetamine or other substances that might be in your system, which makes it more important to seek out medical assistance. It's dose dependent, so the more opioids you have in your system, the more naloxone you'll need, and a shorter half-life than common opioids. So meaning the effects of the naloxone may wear off before the opioids do. And so you need to be prepared to either administer another dose or seek emergency medical assistance. And then I just share here, this is from an awareness campaign that ran up here in Illinois from Prevention First. They took real life examples of people who had been saved with naloxone. Sometimes you hear these stigmatizing stories or these responses, how many times are we going to save someone? And my argument is you should save them every single time. You should always save someone. If someone is sick and dying, you should make every effort possible to save their life. And so this campaign is a really great illustration of why it matters so much that we work so hard to save every single possible life we can. That today is possible because of naloxone. And here's an example of someone who is saved with naloxone and says, I'm a wife, I'm a mother, I'm a homeowner, I am a recovery advocate. Because I was saved with naloxone and treatment, I am able to be who I am today. Just really powerful message and so important. I mentioned before, seeking medical attention and how valuable that is. Again, overdoses are complex medical emergencies, and the best place for them to be treated is in a professional medical setting, even if you have naloxone on hand. So really want to encourage people to call for help whenever possible. And part of what's supposed to do that, encourage people to call for help, is the Good Samaritan law. And those exist at the state level and provide protection from criminal penalties for people who are experiencing an overdose or the people who might be calling for help in the event of an overdose. They're documented and research shows that they reduce opioid overdose deaths, but without increasing use, which is true of many harm reduction interventions and strategies. That's sort of where the evidence points us on those things. I'm going to share a couple details here about the Florida Good Samaritan law. Basically, in Florida, the law provides protection from certain offenses. Most commonly, what we're talking about there are the use or possession of drug paraphernalia and the possession of small amounts of controlled substances. It also protects people not only from those charges, but also from violations of probation or parole or pretrial release. And basically, it's both the person who's kind of seeking, in this case, it's the person who's seeking medical assistance for someone experiencing an alcohol or drug-related overdose, and the person who's experiencing the overdose who's in need of medical assistance that are protected by the Good Samaritan law. Again, people have kind of reasons for being skeptical of that, which we'll talk about here, but this law is on the books in Florida, and something that is really important for people to share is, hey, when you call for help, the law protects you from being arrested, charged, or prosecuted or penalized. Understandably, people might be skeptical of that, but that is what the law says. They're going to be protected if they call for help. And too often, historically, people have not called for help because they're afraid of the criminal consequences that might arise. Here's some additional considerations when you're seeking when people are seeking medical attention. When you're making the call, you want to focus on the physical symptoms. This person fell out, they're not breathing. If you do have knowledge of what substances they took, you can share that. Stay with the overdose victim as long as possible, as overdose can recur. So I think for you all as professionals, you're obviously going to stay with the person until help arrives, but we want to encourage participants and clients who might be around when an overdose occurs to stay as well. And if the person wakes up, maybe from like the first or second dose of naloxone, we want to discourage them from taking additional drugs. They might be experiencing some withdrawal symptoms, some discomfort from receiving the naloxone. And so their first inclination might be to use more. We have to let them know you experienced an overdose. They may not realize, they may feel like they just fell asleep for a second. If someone is still unconscious and for any reason you have to leave them unattended, for instance, you have to answer the door or let paramedics into the room, you want to place someone on their side in the recovery position. And, if people are concerned about the legal consequences, I think this is less significant for professionals, but to keep drugs and paraphernalia out of plain view, right? Just if people are worried about the legal consequences, just move it aside, toss it in a drawer, but, kind of get it out of the way if you're really concerned. And if you don't want to call for medical help, and you can, try to transport the individual to medical attention or the hospital, or as another example of someone who doesn't want to stay around, I talked to someone who said, I called for help. I waited until I saw the sirens out front, and then I unlocked the door, left it open, and went out the back door. So finding ways to get people the medical help that they need in these situations is really valuable. And again, just having these conversations, being creative with people is really important. Last, pharmacotherapy. Methadone and buprenorphine gives an alternative to illicit opioids containing fentanyl. It helps people manage withdrawal symptoms, reduces their risk related to illegal drug use, and reduces overdose death. And studies also show that all-cause mortality is actually reduced by things like Suboxone. So for whatever reason, people kind of go on to lead healthier lives also. So just really important that we make sure people are aware of these resources and try to break down some of the stigma around using methadone and buprenorphine. There's definitely a lot of people in the recovery community who still kind of treat this as with some skepticism or as though it's not true recovery. And at the end of the day, the most important thing is that we keep people as safe as possible. And we know from years and years of evidence now, methadone and buprenorphine are extremely effective at doing that. I'll also touch on here the international approaches. So we have some really great strategies here in our country that are already being employed and should be expanded. As I mentioned, expanded access to methadone and buprenorphine, or additional drug checking services, things like that. There are some international approaches, things that we haven't quite gotten into yet. So things like large-scale drug checking services. So these are usually, in some cases, actually partially funded by government dollars. But they actually pay for programs where people can send in their supplies, send in their drug supplies, and have them tested in a laboratory to determine what the content is, if there's fentanyl in it or if there's other contaminants in it. We have something similar here called drugsdata.org or ecstasydata.org. Basically, it's a DEA licensed laboratory that's able to accept drug samples and test them. But there's a lot more limitations on that than there are with other drug checking services. Other strategies, things like safer consumption sites or overdose prevention sites, supervised injection facilities, these have lots of different names, but the image you're seeing here is actually from a supervised injection facility in Sydney, Australia. So you can see there's someone at the desk, there's a desk worker here, and there's off to the side, there's some other staff members. There's nobody in the clinic at this time because it was during a tour that this photo was taken, but you can see what the station looks like, where someone might use the kind of table with a couple chairs so people can fix up their dose, a syringe disposal box, and there's staff there. So if an overdose were to occur, there would be someone there to help out. These are not, these are not scary facilities. These are very kind of clinical looking. They help keep people safe. They have prevented thousands of overdose. They operate in, I visited the one in Australia that's pictured here, but there's, they operate in Europe as well. It's a strategy that's starting to gain some traction here as an idea in Philadelphia, in Rhode Island, in Illinois, in California, different municipalities. I do think that we'll probably see this strategy employed sometime in the next 5 to 10 years in different parts of the country, of our country. So that's something that's sort of on the rise. State supply programs, and I just want to acknowledge, we're going to go a couple minutes over since we did start a couple minutes late. But so, for those of you who have other things you need to get to, I understand we are going to go a couple minutes over and make sure you get your full 2 hours to CEUs. So yeah, so I'll just kind of continue on here. Safe supply programs basically provide a prescribed alternative for people who are using certain drugs. So for instance, people who might be dependent on heroin can get prescribed hydromorphone or essentially a prescription opioid to sort of take the place. And those safe supply programs ensure that people aren't getting drugs that might be tainted with fentanyl or contain other unknown substances. And those programs have been pretty successful at getting people connected to a more steady supply of substances in countries like Canada. And sort of the added benefits there are cutting down on sort of all the other things people need to do to acquire illicit substances. And a similar kind of philosophy has happened with heroin-assisted treatment programs that exist in Europe. And these are programs, typically they're reserved for people who have already tried methadone or buprenorphine. They've already tried other treatment resources. So this is sort of like a, safety net fallback option for people who really just can't get over or can't get past their heroin use. And they actually prescribe heroin to people. So prescribing drugs like whether it's prescription opioids or prescribing actual heroin for people to use as an alternative to accessing the illicit market has been shown to be really effective at keeping people safe, at avoiding a lot of the other consequences from illicit drug use. All of these are different strategies. You see the resources there, but there's a lot more information out there than just what's on these slides or the references on these slides. So if you are curious about some of these other strategies, and I think in time we will probably see a lot of these being implemented here in various fashions. But, similar to other things, it might just take a little bit longer to get here. I mean, so these are all already being employed in other places. It's a question of if and when we'll be open to using these strategies to address the overdose crisis. My hope is it doesn't have to get much worse before we're willing to do that. Choosing what we say. So kind of as a closing point here, I do want to just sort of come back to this idea of what we were talking about before is, as an example, how do we talk to people about their fentanyl use or about their substance use? Say we hear from a local syringe service program that they shared on Facebook that they've heard reports of a batch of heroin going around that has large amounts of fentanyl in your area and has caused multiple people to overdose. In your next outpatient group counseling session, you A, don't mention it because all of your clients are pursuing abstinence. B, share the information with the group members, warn them about how deadly fentanyl is, remind them that it's a good reason to quit using and commend their choice to stop using. Or C, share the information with the group, ask them what they make of it and what else they know about it, and explore strategies to stay safe. My hope is that, based on the information that you got in this training today, that you'll choose option C, that we acknowledge that people, even if they are pursuing abstinence, are still at, there is still a chance that people will go back to using, that many of the people who may say they are pursuing abstinence might actually be continuing to use in spite of that, and that just trying to scare people out of using drugs by warning them how dangerous it is or sort of just trying to reinforce like, oh, it's a good thing you quit, that's not really going to be the most effective thing we can do for them. That being honest and open and having these conversations and helping people identify for us what their reasons are for staying safer or strategies are for staying safer, that's really going to be the most effective thing possible. And that when we can, that we fill in those holes in knowledge or the gaps in knowledge where we identify them. So again, just to reiterate some of the things we've talked about throughout the morning, find opportunities for this discussion, whether it's looking at urine screen results, an assessment, or in your group or individual sessions, to be curious about what people know, about what they think about this, and to ask and listen before providing information. Right? Before we hand out our fact sheets or share our details, we want to know what people know already, because no one likes hearing information that they already have. Avoid scare tactics. You don't have to use colorful, over-the-top language. You don't have to call it the demon drug. It is a drug, and like any drug, it can be used more safely, and like any drug, it can also cause harm depending on how it's used. And remember, talking about fentanyl does not inherently create an urge to use. I think sometimes this is a barrier for us actually talking to people about their substance use, is if we think, if I mention fentanyl, that might be the reason that someone goes out to use. And again, what's more important is that we make sure people have accurate information, and that you talking about drugs is not the reason that people end up going out to use, right? People who are pursuing abstinence or pursuing recovery, they think about using whether we talk about it or not. And so the most important thing we can do is make sure they're equipped with the education and the resources that will be most helpful to them. So I want to close where I started today by reminding you that today is August 31st. It's International Overdose Awareness Day. And the reason we spent the last 2 hours today talking about fentanyl is because people are dying at alarming rates right now from overdose, especially overdose involving fentanyl. And so it's important for us to know about it, to be equipped to talk to the people we serve in our programs so they know about it. And it's why harm reduction and overdose prevention strategies are just so important. So I want to close with a reminder that, a call to action, I would say, for all of us to talk more about overdose. Today's a good day to go find something to share about overdose on your Facebook or Twitter or, whatever other people might be using. I haven't figured out TikTok yet, but, some of you may have. But, now is a good time to bring up the topic of overdose, to put it out there in your community, to put out, reasonable information about naloxone and safety strategies, but also to bring this up in your groups and your individual sessions that you facilitate, whether you're going to go do a group right now or maybe later this week or even next week, to try to make space for people to talk about it, to share about losses that they've experienced related to overdose, to share about their own personal experiences of having an overdose, and to spread this message that overdose death is preventable. Overdose Awareness Day gives us the perfect opportunity to open the door to these important conversations and save lives in the process. I encourage you to do so, and I thank you so much for your time today. I'll just take a quick minute to click through some of the slides so you can see the references in the recording of this presentation as well. And then Becca, if you have any other final notes for people, you can share those now. And thank you all so much again for having me. Such an important day and such important work you all are doing. I really can't say it enough from the bottom of my heart. Thank you so much for the work that you do.
Unfortunately,
Becca, sorry, if I can show them the slides.
Okay, James, I will need to show this as well. So, and then I will take back over.
Okay, great. So sorry, just to go through the slides, these resources really quickly. These are some of the syringe service programs and harm reduction programs that exist in Florida. Great resources for you all, important for people to have the information that these programs are available in their community, especially for people who might be continuing to use in your programs, but people who know people who are continuing to use. Some additional harm reduction resources, including how to access naloxone in Florida. And then these are just some of the references that I've provided throughout the training. So you can check those out if you want any additional information on these topics. And the presentation will be available, both the slides and the recording of this presentation will be available. And actually, I think if you scroll to the top of the chat, you'll also be able to see a link to the presentation and a PDF version of the slides. Again, a lot of references. I'm just going to keep clicking through these so you can see all of them. And there we are at the end. All right, Becca, thank you so much. You can take back over now.
No problem. Thank you so much, James. All right, we have included Mr. Kowalski's contact information so that you may contact him with further questions. James, we really thank you for all the work you put into this webinar and all the valuable information you have shared with us today. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FATA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for the webinars through WebEx link and when you set up your profile through FATA system. This helps connect your attendance with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. Evaluations will close at midnight on Monday, September 6th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 days after the event. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and please hold for the evaluation.